It's a good afternoon, not a good, good morning. It's always a pleasure to stand in front of you and talk. But yesterday I thought, what should I say? What should I do to serve this 10 minutes of your attention? So I actually came up with two things. The first thing I would like to do to share personal experience. But the second thing is about this guy. I think you're all familiar with. Maybe you got sick of it because you see it too much in the news. But next time you see it, you'll be glad to see how this would happen. Okay. Dehydration is another obstacle, another challenge for me. My name is Ihab Munshi. I'm a researcher, but also a surgeon. A surgeon who should stand straight, talk seriously, and tell you, once upon a night shift in an emergency room, I've met Sarah. She's a 70-year-old. She was tired. She came to the emergency. And while talking to her and examining her, I found out that she had an ileostomy and a scar. It means a surgeon has been there. What have we done? Okay, getting back to Sarah, I went out and I get back to her file and I found that Sarah, I've met before, like 6 months before. She was stronger, she was alert, she was happier. But then, I remember when she got diagnosed with rectal cancer. And then, she just lost some weight and noticed some blood in her stool. And she received the news of the cancer, that she gets cancer, but it was a good news. It was early, it was operable, it was curable. That was good news. But this good news hid behind it a long journey of strenuous, exhausting therapies. She started with radiotherapy. The aim of radiotherapy is to shrink the tumor so it will be operable, so we can take it out. But the downside is the radiotherapy not only affects the tumor, also affects the healthy tissue around it. Afterwards, she comes to the surgeon table and she gets operated. And in this operation, as we speak before that, we'll take the affected part, but we also take the fat around it, and then we will connect the colon with what's left of the rectum, and this connection called anastomosis. It's a good thing, so the patient will have a bowel continuity and will have a bowel function as normal, but this new connection, anastomosis, has a problem. It can leak. Why? Because if you see here, we have taken this fat that embrace the colon, but now it's exposed and it's irradiated, so it's weak. So those patients, as an answer, will have a temporary ileostomy. That means that we will divert the bowel content, so the anastomosis will get healed. Woohoo! We did it again. We will cure the patient can go home. But then the patient, without noticing the file for Sarah, that she's keep coming to the emergency room because she's having dehydration. Dehydration is one of the consequences for the ileostomy. They will lose a lot of fluid, especially in the first period. So remember when we sit together in pairs and ask ourselves about our main messages and those questions, I will go through these questions very quickly. Why do I think dehydration is important for this patient? This patient is not only fragile, but for us, we can just drink water. But for them, it could be a matter of few hours or few days, and they could end up in acute renal failure because they already had tumor, they're already old, and they're fragile and very exposed. And this is a new physiology. When is it critical for dehydration? Researchers have shown that it's the first 6 weeks after getting a discharge from the hospital get more dehydrated than other periods. How many of them? Unfortunately, 1 in each 3 patients we operate with this operation will get dehydrated. Half of them will be admitted for this problem. So that's why I think that we need to come up with a solution for Sarah. So we have gathered and said, okay, what should we do? What should we do? We came with a plan. It's a 3 steps. It's easy. It's clear. The patient, when they get home, they will leave blood sample every 2 weeks in the next 8 weeks. So in the same period, they're more critical for. And then a nurse will call them and see. If there wasn't any abnormal blood test, they will call them and check on them. Didn't you drink water as usual? Did you have more discharge from your fluid, from your ileostomy? And then a surgeon with a nurse with a patient will put a plan to follow them up, to take more lab tests, or to admit them maybe. Okay, so I think we have succeeded. So what's the result? After 2 years of working on those patients, we have collected around 87 patients, and we had a control group of 92 who didn't have this intervention. This is a group from the past. And those groups, like we said, 1 in each 3 had have dehydrated, half of them readmitted. So what's our result? Nothing happened. The same dehydration, the same readmission. We're not done yet. As our friend said, we won't fail if we're not pushing it too hard, if we're not innovating, if we don't dare enough to break these norms. So I get back, maybe just to comfort myself that we did something, and look closely, what have we done wrong and what have we done right? When we look at this page, at those patients, this group, all of them actively reached the hospital because they had a complaint. Either they were tired or they had a high flow from the stoma, so all of them were symptomatic. But those one, as this could show us, were 13% of them were asymptomatic. It means they didn't suffer from anything. They continued their life. They didn't feel anything, but they were dehydrated. Yes, in the lab wise, they were subclinically dehydrated. So the thing is, like with Sarah, she wouldn't have to come to the hospital because we would pick her up earlier. And that's why I think it was very great of those nurses that they could follow up those patients, reassure them in this critical period. So the last thing, I would like to say that this man, you will hear about him a lot. You will read news about his innovations as well as his failure. And he will be remembered in the coming years because he had a dream. He has a dream and he's working for it very hard. And this dream is to put the first man on Mars. Yes. But what I want you to remember, I want you all to remember that if he would be appraised for putting the first man in Mars, Joao, Christina, Johan, and every one of you should be appraised because what you're doing every day is what's making Sarah's and everyone's life better on this earth, on this planet. Thank you so much.
Thank you very much. I have just keep the presentation, and now you get some questions here on the content.
Elon Musk, please.
Elon Musk. Okay, questions for you. Now I have.
Yeah. What was the definition of dehydration? Great. I didn't get into the definitions, clinical definitions, but those patients. First, we have a laboratory definition. If the creatinine is increased more than 130, if the sodium less than 125, or they had a creatinine more than 1.5 times on their basis, on their basic reading, and that was the KDIGO, it's the Kidney Association guideline definition, because it's really important to define which one is dehydrated or not. And we can define it based on the laboratory readings or based on how much is coming out from the stomach. Is it more than 1.5 liter, 1.5 liter per day for 1 to 3 days, or they lost 1 to 3 kilos? So that was a good question in reading the literature, because some of them are not really specific on the definition of dehydration. Thank you.
Question. How did the study group look like? Were they a homogeneous group or about the same age with the same type of diseases or?
Yeah, we have compared the control with our group, and then we have compared our group, the non-dehydrated versus the dehydrated. The thing that you can see, the factors that will give you dehydration is all age, and which is compatible with other studies also, and taking diuretics. One study only showed that those patients who had taken osteohemorrhage, OSA inhibitors, they had more risk. And it wasn't compatible with ours. They didn't, but it could be also the sample was. We didn't have a lot of patients on antihypertensive. But there is, in the literature, the patient who's having new adjuvant. So there are also, yeah. So those are the risk groups.
Lee, please.
Yeah, it's good presentation. My question is, as Simona said, the different factor maybe aging or sex and something, the culture I think maybe. But do you want to analyze like different factor like age and sex or something? The cultural background maybe different understanding. Maybe they can't follow the instruction. Yeah, you know that.
That's a very good question because we have to predict which patient should we be more careful with them because we should follow them more. Those factors were age, medication that they're taking, if they will take chemotherapy later on or not. But the sex didn't make any difference. The ASA class, the American Association for Anesthesia class, didn't make any difference. We also correlate the renal function test before the operation. It didn't have any difference. In literature, it showed that previous surgery have also contributed to increased dehydration. But it didn't have.
One last question.
Okay, final one, yes.
Does it matter where you put the ileostomy?
It's a surgically adjusted. It means that it doesn't matter. It just matters how many small bowel do you have, because the longer, the more absorbent. But regarding the body, it doesn't matter. It should be somewhere the patient can reach and see. It should be, they say, between muscles, so it will not be a slap. And yeah.
But is it a low ileostomy or high?
It should be at the least a terminal ileum, so we will have all the capacity small bowel to absorb.
Okay.